Hi, my name is Dr. Lin. I am a third-year pathology resident here at UT Southwestern. I grew up in the DFW area. I went to high school in Plano West, and then I went on to get a degree in chemistry. And then I came here for medical school. I used to sit back there when I was a med student. And during my time in medical school, I also took some time off to get a master's in biochemistry. And I know that when I started med school, I did not know what pathology was. But I met some people, some attendings and residents who were pathology, and I found that I really enjoyed it as a field. It's a great subspecialty of medicine, and we really get to answer a lot of diagnostic problems for our patients. So I decided in residency that it was one of my missions was to help raise awareness of and spread knowledge of the field of pathology. So I'm very excited to give this talk about cancer. I want to first talk a little bit about just generally what cancer is, and then I want to go into one of my favorite topics. I'm going to be a fellow in hematopathology, so I'm going to talk a little bit about some specific blood cancers in some of our patients that we see. So first I want to talk about if we see patients in the hospital, what are some possible signs and symptoms that they might be complaining about that would make us think this is a little concerning for cancer? So patients might complain about a lump, for example. This is not uncommon. Patients will say that they've had a mole on their skin and that it's started changing color or growing, and these are concerning for example, a melanoma, the type of skin cancer. Patients often complain about being very tired. This is because cancer essentially robs your body of all of its energy and of its nutrients. And this leaves patients feeling very exhausted. Sometimes a cancer can manifest as a rash. Of course, this is not very specific, same as fatigue. Just because a patient shows up with a rash doesn't necessarily mean they have cancer. But let's say there's been a rash and it has been treated with steroids, doesn't go away, and we don't know what's causing it, then it could possibly be related to cancer. Abnormal bleeding. Patients can have, for example, tumors in their lungs, and this can disrupt the vasculature in their lungs, and this will result in them coughing up blood, which is very concerning. A prolonged cough, similar idea. If there's a tumor in your lung, then this will cause difficulty breathing and therefore cause patients to have quite a bit of coughing. Unexplained weight loss. So because cancer is depriving our body of the energy and nutrients it needs, it can lead to some very dramatic weight loss in patients. So I've seen patients who come in and they'll say that they lost 30 pounds in the past month. And it's not because they were on some new diet or like that they were trying to. They just lose it very rapidly and very suddenly, and they come in looking very ill as well. So you can see that they have, like at their temples, that the skin is sunken in. Change in bowel movements. This one is pretty interesting. So what happens is that patients will come in and they'll say that, oh, I've had stool that is pencil thin. And the reason for this is that if you have a tumor obstructing your colon, for example, then the stool that passes through is obstructed by that tumor, and it will come out very, very thin. And headache. So if you have a tumor in your brain, this will cause, it makes sense that this will cause a headache. For example, a glioblastoma multiforme is an example of a brain tumor. This came into the news some years ago because John McCain had a glioblastoma, and so did one of Joe Biden's sons. So what is cancer? This seems like a relatively simple question, but it's actually quite complex. It's something that a lot of people still debate exactly what it is today. We define cancer as a group of diseases involving abnormal cell growth with the potential to invade or spread to other parts of the body. There's more than 100 types in humans, which is why it's very difficult to cure cancer. There's so many types, and each one responds differently to different therapies. We say that it's initiated by damage to the stem cell DNA, so it could be something like radiation, like if you're in a tanning salon. It could be something like if you drink boiling water and you damage your esophageal lining too much. Anything that causes damage to your stem cell DNA can cause a cancer. And I like to think of it as a balance between what we call proto-oncogenes and tumor suppressor genes. So proto-oncogenes is it's a long word for a group of genes that causes cell growth. And tumor suppressor genes, on the other hand, is a group of genes that says slow down, stop growing so much. And both of these are important in our everyday lives. We need genes that tell our cells when to stop growing so much, but we also need genes to tell our cells to divide and to grow. We have cells like in our hair, for example, or on our skin, or in our GI lining that constantly need to be replenished because they get shed every day, and we need to keep growing them. However, the problem with cancer is when there's a imbalance between these genes. So for example, if there's too much of the proto-oncogenes and too little of the tumor suppressor genes, then we get abnormal cell growth of cells multiplying too quickly. How does cancer kill someone? And I know this also seems like a simple question, but just having an abnormal lump in your body or having a cell that has damaged DNA in itself is not the cause of the problem in itself. We do have benign tumors. Benign tumors, we will say that they remain localized. They don't move and they don't metastasize. On the other hand, we would say that malignant tumors are cancer, and for the purposes of this talk, I'm just going to say that malignant tumors and cancer are the same thing. This is another topic of debate that I won't get into. But these have the potential to invade and the potential to metastasize. And a metastasis is when you have, for example, let's say there's a breast tumor. And then it has access to vasculature, so it can go through the blood vessels and access a different organ. And then that breast cancer shows up in the liver, for example. That would be a metastasis of a breast cancer. And the reason that this is really bad is because tumors have the potential to shut down organs. So that metastasis that ended up in the liver, it could overwhelm the liver and cause its normal functioning to stop. Normally, the liver is important for us because it helps metabolize toxins in the body. However, if the liver is not able to do that, then toxins will accumulate in our body, and that can kill us. So to further illustrate what I was talking about, I want to point out this little graphic here. So we see here, this could be, for example, our skin. And these are normal cells up here. They're respecting this boundary here. And this is our vascular down here. So we have our lymph vessels and our blood vessels. But then we get something like maybe we were out in the sun and we got sunburned too many times. Now we have damage to these cells and their DNA has mutations in it. And this in itself here is okay. But what's problematic is that these cells will divide rapidly. And they'll turn into what is this here, where now we have a lump. This could be a mole on our skin, for example. And this here it's also okay. It's still respecting its boundaries. We do call this cancer in situ at this stage. Unfortunately, what can happen from there is that these cells can break through the boundary and access the vasculature. So they can access this blood vessel and this lymph vessel here, and now they can travel throughout the vasculature and access other parts of the body. How do we treat cancer? I have one example up here, that's chemotherapy. Chemotherapy is defined as a chemical that binds to and specifically kills microbes or tumor cells. We don't really use chemotherapy for microbes nowadays. We have a lot of antimicrobials that are much better for that. Historically, chemotherapy worked by causing DNA damage by preventing rapid cell division. And this seems like a strategy that would work because tumor cells, cancer cells, are cells that rapidly divide. That's why they're so problematic. However, the problem with this is that there are many other normal cells in our body that also rapidly divide. So like we talked before, our hair is something that rapidly divides. So is the lining of our GI tract. This is why historic chemo drugs have caused hair loss, have caused a lot of problems with GI problems because they targeted not only the cancer cells, but also the cells that rapidly divide, such as our hair or GI tract. This is why in more recent times, research in chemotherapy has focused on developing drugs that bind specific cancer molecules or inhibit cancer protein functions. That way, they're more specific to cancer cells and don't cause problems with our normal cells. Some other ways that we use to treat cancer. So surgery can be a great way to treat cancer if there's like one localized, easily encapsulated tumor. We can cut it out, and sometimes that is a really great and curative option for patients. We also have radiation therapy. Radiation therapy is it's very great at killing cells. However, radiation therapy is tricky because it does not discriminate at all between what's a cancer cell and a normal cell. So we have to be very targeted with where we aim radiation because we could end up causing a cancer due to it causing DNA damage. And then there's also some more specific cancer treatments. For example, for our leukemias, those are things that we can't use. We can't cut out blood cells out of the body. We can't irradiate blood cells because it flows all throughout your body. So an option we can use there is something called a hematopoietic stem cell transplant. And that's where we basically irradiate and start the marrow over and then give the patient a new bone marrow. It could be their own if they didn't have problems with it. And basically start over with their bone marrow. Now I want to shift gears into specifically some hematopathology. So I want to talk about leukemia, which is blood cancer. And here we have, this is a blood smear. This is what happens when you take blood from a patient and then you put it onto a microscope slide and smear it out and then look at it under a microscope. And this one is a normal one. So the things I want to point out here are that there's all of these red donut-looking things. These are our red blood cells. These are our platelets here. And we have these cells that that look more purple. These are called nucleated cells. These are our white blood cells. And the thing I want to point out here is that we have a diversity of cells. They don't all look the same. So these here, these are neutrophils. They look different from this cell up here, which is a monocyte. And they also look different from this cell over here, which is a basophil. The way I like to think of analyzing a blood smear is that if I look out at a group of students, for example, I expect them to look different from each other, and that's great. That's exactly what I want to see. However, if I look out and I see everyone is Agent Smith from the movie The Matrix, I would be very scared. That means that there's one abnormal person or cell, and they are just taking over. So we'll see an example of that in a little bit. And the other thing I want to emphasize here is that the white blood cells are relatively few compared to the red blood cells. And there is a such thing as having too few white blood cells, but what you also don't want is to have too many white blood cells taking over. So leukemia. We've known about leukemia ever since the 1800s. There was a doctor named Peter Cullen in 1810, and he was examining this 35-year-old male patient who came in with pronounced abdominal pain, symptomatic fever. Back in the day, they used to treat patients by bloodletting, which is, it's not what we do anymore. But when he did bloodletting on this patient, he observed that the blood was milky in color and consistency, which is very abnormal for blood. It should not look like milk. And then another doctor in 1827, Alfred Velpo, he saw this 63-year-old patient who came in with pronounced swelling of his abdomen, fever, weakness, recurrent fevers. He had quite a few medical problems over the years. He also had 2 tumors in his abdomen. He unfortunately passed away. And Velpo performed the autopsy on this patient and found hepatosplenomegaly, which is a word that means that both the liver and the spleen were very large. He also described the blood as looking like thick, like gruel, and filled with pus, which is very, very abnormal. So we can see here on the left, this is an example of what those 2 doctors may have seen. On the right here is what we should see when we examine blood from a patient and then spin it down. We should see these RBCs down here at the bottom with this transparent, clear serum on top. But for these patients, it looked like this with this thick, gruel-like substance, which is very different looking than we expect. Now I want to talk about Rudolf Virchow in a little bit more detail because he has quite an interesting story. He was originally planning to be a pastor. He was the son of a farmer. He decided that his voice was too weak for preaching, so he decided to go into medicine, and he got a military fellowship for gifted children from poor families to study medicine in Berlin. In 1845, he saw a patient. It was a 50-year-old female, and she had leg edema, which means that her legs were swollen. Splenomegaly, which means that her spleen was large. Diarrhea, she'd been having nosebleeds. She was quite sick, like those other 2 patients, and unfortunately, she passed away within 3 months. And when he did the autopsy on her, he saw that she had a hypertrophic heart, which means a very large heart. Her aorta was also quite large, and her lower extremities, which were swollen, were filled with a greenish yellow-white substance, like pus again. And she also had a very large spleen. And under the microscope, her blood smear looked somewhat like this. This is not exactly her blood smear, of course, but it would have looked like this. So we can see here, in contrast to the previously normal blood smear that we saw, it looks pretty different. We can see that that relatively there's a lot more white blood cells, these blue-purple cells, compared to the red blood cells. And we can also see that these cells look all similar to each other. They don't have those differences that we saw earlier. So this is quite concerning. This was the first paper to describe what we now know as leukemia. And what I find really remarkable is he did all this work while he was still in medical school. So after he did all of this work, he then passed his medical licensure exam. He went on to become the father of modern pathology. He did numerous things in his career. He investigated the 1847-1848 typhus epidemic in Germany, which laid the foundation for public health. He was considered the founder of social medicine. Because of how he grew up, he really cared about making healthcare equitable for all. He believed that everyone deserved access to healthcare and medicine. He also participated in the Revolution of 1848, which led to his expulsion from the hospital. But thankfully, he was later reinstated and went on to do many more great things. In his career, he went on to write more than 2,000 scientific writings, which is quite a lot. I find that really amazing. He also developed the first systematic method of autopsy, which we still use today. He introduced the idea of hair analysis and forensics, which we also still use today. He helped the practice of meat inspection. He did a lot of work on this roundworm, Trichinella spiralis. So we have him to thank that we don't have to worry so much about Trichinella in our pork today. And now I want to fast forward a couple centuries. So this was last summer. This was a patient that I saw when I was on service. This is a 51-year-old female. She had a past medical history of just asthma. Otherwise, she didn't have any other history. But she had 1 month of fatigue, recurrent upper respiratory infections, and shortness of breath. And we may remember from the beginning of this talk that those are some concerning signs in a patient. We're a little bit concerned about a cancer or a leukemia. She also had her blood tested, and it showed anemia, so a low red blood cell, low hemoglobin, and she also had low platelets as well. And this is her blood smear from that time. So you can see here that similar to the other patient with leukemia, there's relatively few RBCs, red blood cells, compared to the number of white blood cells. There's quite a few white blood cells. And these white blood cells, unfortunately, all look very similar to each other. And there's one more thing here that's very concerning. And that's these rods that we can see here that these arrows are pointing to. And I know we haven't talked about these, but these rods are very concerning for something that is called acute promyelocytic leukemia. So acute promyelocytic leukemia is a specific leukemia that's characterized by these are promyelocytes, and these are immature blood cells. It's very concerning because when it was first characterized in 1957, it was called a hyperacute fatal illness. And the reason for this was because a patient would come into the ED, kind of like this patient, and their median survival would be less than 1 week, which was very, very scary for these patients. It was found that these patients have a very specific genetic mutation. So they have a translocation between chromosomes 15 and 17. And the reason that this is a problem is this causes a fusion between these genes, PML and RARA. However, when we discovered what the genetic mutation was, this meant that we could design therapy that would specifically target this problem. So ATRA, all-trans-retinoic acid, this is actually a vitamin A derivative, but this does target this fusion here, and it helps the immature cells progress along their pathway of maturation. And it really changed things for these patients. So the 5-year mortality went from 82% to 36%. It very much helped patients live longer when they were on ATRA. So naturally, we put this patient on ATRA, hoping that it would help her. Unfortunately, the patient did not respond to ATRA, so we wondered what could be the problem. So this here, so we have in pathology, I was looking at this in the hematopathology department. There's other subspecialties of pathology. There's also, for example, cytogenetics. Cytogenetics is where they look at karyotypes. So diagrams like this, where we can see our chromosomes, and they analyze. And for a patient with acute promyelocytic leukemia, we can see here that on chromosome 17, there's a chunk that's missing. And that's because that chunk has moved over here to chromosome 15 and has fused with it. So we asked our friends in the cytogenetics department if they could take a look at our patient and see if her karyotype looked like this. And they took a look and they said, actually, no, this patient doesn't have that translocation between chromosomes 15 and 17. What they actually have is over here on chromosome 7, you can see that there's a piece missing from here that moved onto chromosome 11. This meant that our patient had a problem that was involving completely different genes than we expected, and this explained why the therapy didn't work, because that therapy was not designed for this genetic mutation. We also talked to our friends in the molecular pathology department. What they do is they do this very expensive and very fancy technology called next generation sequencing. So what they do is they take the patient's DNA and they extract it from the cells, and then they amplify it a lot and compare it to this a library of DNA, what we know about the human genome. And then they run it through the machine and sequence the whole thing. So they find out the exact sequence of ATCG that is present. And then they analyze it and see what mutations are present. And they did find that in this patient, there was a mutation that we did not expect. So because we now know what mutations the patient has, we were able to start her on an appropriate chemotherapy regimen. And she did improve with this therapy. And her most recent bone marrow exam showed no residual leukemia left, which was great news for her. And because of that, we published these results. We published our findings in a journal. And the reason that this is really important is because, let's say, for example, a doctor in another hospital sees a patient with a similar problem like this. They see rods in cells, and they think that this may be acute promyelocytic leukemia, and then they start the patient on ATRA, and the patient doesn't respond. Then they can look up and see what other people have done, and they may think that, oh, we should look for this unique translocation that has been found, and we should test for that. And if they're positive for that, then we know how to treat them. And I wanted to spend a little bit of time talking about what do we do in pathology. So I talked about a few different examples. In hematopathology, what we do is we take a look at patients who were concerned about malignancies of the blood or of the lymph system. I talked about cytogenetics, where they analyze chromosomes, chromosomal translocations, they look at karyotypes. And I talked about molecular pathology, where they run next-generation sequencing to look at genetic mutations. What other things do we do in pathology? Pathology is a very broad field. So there are some people in pathology who work on transfusion medicine. An example of what transfusion medicine does is patients who have sickle cell disease often need a lot of transfusions. So they'll need a lot of red blood cells, for example. Transfusion medicine are the doctors who manage that. There's also microbiologists. Those are doctors who diagnose things like malaria, dengue fever, and parasites. There's also forensics pathologists. They do things like investigating suspicious deaths. They also do something called bone hunting, which is where, for example, You might be out walking your dog, and your dog might find a suspicious looking bone, and you may get scared because you shouldn't be seeing large bones out when you're walking. So you would call someone and ask, can someone take a look at this and make sure it's not a human? The person investigating that would be a forensics pathologist. Pathologists also do organ and bone marrow transplants. Whenever we do a transplanted patient, we have to be very careful of who is the donor and who is the recipient. We want to make sure there's a good match. So there are doctors, pathologists who handle that. Pathologists also do DNA testing, and they also do routine blood test analysis. So when you go to the doctor for your annual physical and you get your blood drawn for testing, then a pathologist is the one who takes a look at it and looks at your hemoglobin, your electrolytes, your cholesterol, to make sure that you're still healthy. And these are my works cited. And the last thing that I want to say is that, so I did make it my mission to spread the word about what pathology is in the hopes that more people will choose to enter pathology. But something else that has caught my attention in recent years is that there has really been the spread of misinformation. So I talked a little bit about how the results that we found from this patient, we did publish them so that other people could read them. Unfortunately, on the internet, it's very easy nowadays for anyone to publish anything on the internet. So I wanted to end by urging you to think about what sources we're reading, about how we know results, and to really critically think about science and medicine in the future. Thank you.